Okay, off you go.
Okay, thank you very much, Dr. Zelentsov, for this introduction. Let me just share my screen here. Can people see my screen?
Yeah, we can see it. Thank you.
Do you see it in regular view or presenter view?
It's a presenter view.
Okay, let me change it. Okay. Thank you, Dr. Zelentsov, for this introduction. My name is Umar Ismail. I'm an interventional fellow in Winnipeg in Manitoba, and I'm here for a month-long elective. So thank you everyone for the past couple of days for the warm welcome. And I'm happy to join you today for the weekly academic rounds here at New Brunswick Heart Center. So what I'll be talking about in the next 20 minutes is basically a review of this article, the revived BCIS2 study that was published recently and presented a couple of times in ESC and ACC, and it basically looked at PCI for ischemic LV dysfunction. And we'll go over this study in detail because this is really the only randomized control trial that we have talking about this subject. The premise or the background to this study, as we said, there are no real randomized trials on this subject per se, while there was a trial, the STITCH trial, that looked at CABG in patients with ischemic LV dysfunction. And STITCH was published over 2 phases. The first phase was in 2011, and it showed that although there was no all-cause mortality benefit in patients with CABG and surgical disease, multivessel disease, and ischemic LV dysfunction, there was perhaps some improvement in cardiovascular mortality and heart failure hospitalization. But then over a 10-year period, there was evidence of improvement in all-cause mortality benefiting the CABG arm versus optimal medical therapy arm. And the idea was that if we have a hibernating myocardium, that we can awake from its dormant state, and that's what makes an improvement. So Revived followed a similar protocol or a similar study design, where they took patients with LV dysfunction with an EF of less than 35%, randomized them 1-to-1 in 2 arms. The first arm was PCI plus optimal medical therapy, and the other arm was optimal medical therapy alone. This was a UK study. It was conducted in 40 centers in the UK, and the recruitment was a bit slow, or the enrollment was a bit slow, and it took over almost a 7-year period between 2013 and 2020 to recruit almost 700 patients. They included patients with an EF of 35% and extensive CAD, as well as viability in at least 4 dysfunctional myocardial segments that they assessed by dobutamine stress echo, cardiac MRI, SPECT, and PET. Now, extensive CAD, to them, they didn't really use the syntax score to analyze that, but they used something that honestly I didn't know until I came across this study, which was the British Cardiovascular Intervention Society Jeopardy score. And what this score is, it's more of an algorithm looking at where disease is and gives a score based on that. So they said this is a score that goes from 0 to 12, and they said anyone with a score of 6 or more will qualify for this study, will be included in this study. And if you just have a look at it from the beginning, left main stem disease, if you have a significant lesion, then you get a score of 8. So if you have, let's say, mid-body left main disease, then you're automatically included in this study. If you have a proximal LAD disease, then you have a score of 6, and you're also part of the study. But if you look at, for example, syntax score, if you have a prox LAD lesion, you get a score of 7, and this is well below, for example, the threshold of 22. That makes you at least moderate coronary anatomy complexity. They had a bunch of exclusion criteria where they they exclude people with previous MIs within the past 4 weeks, heart failure requiring inotropic support within the past 72 hours, arrhythmias, ventricular arrhythmias over the past 72 hours, valve disease requiring intervention, previous CKD, or contraindications to PCI. So a couple of points here, noting about their protocol. So they ended up with 700 patients over a 7-year period, and they randomized them 1-to-1 in either arm, followed them for a minimum of 24 months, but an average of 3.5 years. A couple of things that, stick out when reading this is, in their protocol, they recommended to the PCI operators to revascularize segments that had viability, or that showed viability on viability study. However, they say that we did not go back to cross-reference or make sure that this is what actually happened, meaning that they didn't cross-reference or go back to see whether the vessel that got PCI was the vessel that showed viability. And then they also wanted to calculate how much revascularization they got by calculating a jeopardy score, which basically they looked at the score that they had with this PCIS score, jeopardy score, before PCI and after PCI, and got a percentage. So for example, if the score before PCI was 10, and then the score after PCI with the residual disease that was left was 5, then they had a 50% revascularization. And they use this to say that, we did good, or we revascularized a large segment of myocardium, to say that, we revascularized a lot with PCI, basically. Outcomes, their primary outcome was a composite of all-cause mortality and heart failure hospitalization. And their secondary outcomes was a bunch of things. So primary components of the primary composite outcome. Secondary outcomes were LVF at 6 and 12 months, death from cardiovascular causes, unplanned revascularization, acute MI, incidence of ATP from ICDs, and also subjective quality of life questionnaires. With intention to treat analysis, and they calculated they needed a sample of 700 patients to be able to get 700 patients with 300 having a primary outcome event to give a study 85% power to detect a hazard ratio of 0.7 for a primary outcome. So what did they find? This was their table 1, looking at demographics. So you can see the average age here was 70 in this study. Males comprised about 90% of the population. 90% of the population were also Caucasians. Diabetics were about 40%. But I think the most important part here is if you look here at the clinical characteristics of the patient. So NYHA function class 1 or 2 was somewhere between 70 to 80% of the population. So around 4/5 of these people had relatively well-controlled heart failure symptoms. CCS angina class, so no angina, 2/3 of these patients, or 2/3 of these people, had no angina at all. And the other third had class perhaps 1 or maybe 2 angina. So these, I think, are important considerations if you are thinking clinically about what to do with these patients. LVF was 27% on average, and coronary artery disease characteristics, 2-vessel coronary disease, made up about 50% of the population. So about half of these patients had only 2-vessel disease, and about 30 to 40% had 3-vessel disease. It was a well-conducted study. I think 96% of patients had PCI within 35 days, and then their average score, the average score that they used to calculate the extent of CAD was 9.3 before PCI and 2.7 after PCI, and they said that they revascularized 71% of disease in this study. They followed patients for about 3.5 months. 3.5 years in 41 months in this trial. Their results, what did they find in their results? So the primary outcome, which was a composite of death from all-cause mortality or death from any cause or hospitalization for heart failure, there basically was no difference numerically, and no statistical significance, 37 versus 38%. The components of the primary outcome, the individual components of the primary outcome, death from any cause, again, no real difference. Hospitalization for heart failure, no difference. Death from cardiovascular causes, nothing that is of significance, 22 versus almost 25%. Some differences were here. Patients with acute MI obviously will have more peri-procedural events. Patients who had PCI will have more peri-procedural events, and patients who had PCI will have less spontaneous events over the follow-up duration of the study. Unplanned revasc was again less in the patients who underwent PCI compared to the optimal medical therapy arm. And these were really the only statistically significant results that they had. Major bleeding, again, if you're going to do PCI, you're going to put patients on dual antiplatelet therapy, and you would expect higher bleeding events with this subset or with this group. Primary outcome with regards to, this is the Kaplan-Meier curve for the primary outcome. So the primary outcome events on the y-axis, and time is on the x-axis. The blue line is the optimal medical therapy arm, and the orange dotted line is the PCI arm. And you can see that these curves hug each other, or they're basically converge early on and never separate. They never diverge, showing that there really was no difference between either arm. Looking at subgroup analysis, for primary outcomes, so they stratify those patients by age, extent of CAD, a degree of LV dysfunction, diabetes, NYHA class, AFib, left main disease, NT-proBNP levels, and there was basically, no matter how you stratify these patients, there was nothing that came up to be statistically significant that favors PCI or medical therapy. LVEF, so this was something that they did not really talk about in detail in this study. The supplementary material of this trial had quite a bit of information, more than the main paper. But basically, LVEF changes, there was no difference in LVEF. So there was no improvement. There was no real improvement in LVEF with PCI over the study period. There was no improvement with EF with optimal medical therapy over the study period, and there was no difference between PCI and optimal medical therapy. They started out with an EF of around 30%, and it never didn't really go up by much. And this is what the EF did if you put it on a pictorial graph. Basically, they start somewhere here and they end somewhere here. Not much of a difference. And KCCQ, Kansas City Questionnaire Score for Quality of Life, improvement quality of life. There was some improvement in quality, subjective improvement in quality of life early on in the PCI arm, but that slowly started dwindling over the study period, and so with some improvement in those scores in the medical therapy arm. And then the last thing perhaps they talked about is whether there was any improvement in outcomes depending on the extent of revascularization. Remember, they calculated their revascularization index, and they had about 71% average. So y-axis is incidence of events, primary outcome. X-axis is time. Blue line is optimal medical therapy arm. A red line, a red dotted line is revascularization less than 80%. Green line is revascularization more than 80%. And again, you can see that the graphs are pretty much similar, and there is no difference in incidence of primary outcome, even if you risk stratify these patients this way. So in conclusion, the trialists concluded that in our trial involving patients with severe LV systolic dysfunction, extensive CAD, and dysfunctional viable myocardium who received optimal medical therapy, the addition of revascularization by PCI did not result in a lower incidence of death from any cause or hospitalization for heart failure, incremental improvement in LV ejection fraction, or sustained difference in quality of life at a median of 3.4 years. I think, overall, this was a well-designed study. It was, the first randomized control trial that we have on this subject per se. The groups were similar. They were treated equally. Everyone was accounted for. The only thing, it was unblinded, but how can you blind a intervention such as PCI? I think the questions that arise after reading this study is seemingly you got with Stitch, you got positive results eventually over when these patients were followed for around 10 years. So why didn't we get something similar here? Was it because there was less patients here? There was 700 patients there. They had 1,200 patients. Was there not enough follow-up time? These patients were only followed up for 3.5 years, while there they followed them up first for 5 years and 10 years. But then I think an important consideration here is looking at the population of these patients per se. So remember, they had patients with LV dysfunction NEF of 35% or less, but half of these had only two-vessel coronary disease, and they didn't really tell us where this disease was. So, for example, if we get referrals to cath patients for LV dysfunction all the time, and let's say in a hypothetical situation, you're going to get someone with a circ lesion, a focal circ lesion, and a focal diagonal lesion. That would be two-vessel disease. A lot of times we'd probably be saying, okay, so this patient has an EF of 30%, but he has this focal two-segment disease, focal two-vessel disease in a diagonal and a circ. So perhaps, the degree or the burden of coronary disease does not explain the extent of LV dysfunction. So, the question here becomes, were these patients that were enrolled in this trial, were they really ischemic cardiomyopathy patients, or were they, some non-ischemic cardiomyopathy or mixed ischemic and non-ischemic cardiomyopathy patients that you happen to find some coronary disease in? So I think that is an important point that they don't elaborate on the procedural details, and the median number of lesions successfully treated was 2. They didn't tell us the severity of stenosis. There was no physiological assessment of the lesions. This was not reported, and they also, remember early on, they said we recommended that these patients get revascularization in vessels that supply myocardium showing viability, but we never really followed up to check whether this is what happened. And then, the score, the BCI score that they used for to calculate, what extensive CAD is. I'm not sure. I don't have much experience with it. I'm not sure what other people feel, or whether they have experience with it, and whether they use it in their day-to-day practice. But perhaps patients with real extensive triple vessel disease or multi-vessel disease were offered CABG outside the trial. And then the last point I think to bring up is, the clinical picture of these patients. So remember, 2/3 of these patients had no angina, and the other third had maybe class 1 angina, while 70 to 80% of them had NYHA or NYHA class 2, NYHA 1 or 2 class symptoms. So if we get these patients to the cath lab and we cath them, and you find, let's say, a focal RC and a focal circ, and then they have no angina and they have NYHA class 1 heart failure symptoms, again, these won't be patients who would be routinely revascularizing, I think, on a day-to-day basis. That's basically it. That's all I had. I think this is 20 minutes. Thank you all for tuning in and listening, and I'd be happy to take any questions.
I'll start, Umar, if that's okay. Everyone hear me okay? So, I think, again, this was the kind of first trial we ever saw with vascularization and low EF, and it's a question we've always had, but I think our historical practice would always be send people with multivessel disease and low EF to surgery, just based on the lots of registry data and observational data we had supporting that, in multiple different for a long period of time. I think, if someone comes from a practical point of view, if we have a patient sent to us for cath, and maybe they don't have any angina, but they have reversible ischemia on a nuclear study or viability, and it's a low risk lesion, I think most of us would probably fix those lesions. And that would be your similar experience in Winnipeg. I suspect that we would do that, even if they may not have angina. So I think it's reasonable to compare that and say that would be similar to what we would do if we've, and I'm just talking from my own clinical experience. If people have dyspnea but no angina but have ischemia on a nuclear study and it's a low risk intervention, we'll fix that, even if it's, they're not limited with angina. So I think it's a reasonable, conclusion from the study. I think I would like to see a longer follow-up, like you said, would be interesting to see. One thing I guess I would say is I'm not sure we can kind of, like the BCS score, I'm not familiar with either, but syntax is kind of just a different clinical question, I guess. For me, this is just whether or not PCI and heart failure is helpful. And that's kind of the simple takeaway I took from this, but there are a lot of details in it. But I guess we've never had any good data to suggest that PCI and heart failure is good. And they try to at least show there was some viability, but I think some of the more technical details around the intervention of complete list revascularization would have been helpful. So, so I guess, do you think following them longer may have been helpful, or do you?
Yes. So yeah, I totally agree with you, Dr. Barry. If you get a patient, for example, even if they didn't have angina, even if they didn't have heart failure, even if they didn't have lots of dyspnea, but then, they come with you with an EF of 30% and you find simple lesions, you'll say, let's revascularize them, because it's straightforward and perhaps in the attempt of improving, number one, ischemia. And number two, maybe you can improve the LV function. But I think it would have been perhaps, yes, more helpful if, we are basing this or trying to compare this with a stitch. A longer follow-up would have been probably helpful. And I think, from what I read, the trialists are also keeping this subset of patients with them to follow up long term. Although, this was a fairly, sick population. If you look, they had 30% mortality over the follow-up period. So this was a relatively sicker population of patients when 1/3 of your population dies over a period of 3 years.
Yes, I would agree. Very high risk patients that we see, but I think, maybe over long term and selected people, revascularization may be helpful. It's hard to know, but again, it's a very high risk patient population. And I'm not sure what the practice, how you feel the practice is in Winnipeg. Probably patients with at least 2 vessel disease and poor LV function, we would kind of have a heart team discussion around these patients for most of them. And I'm not sure what your practice is, but maybe Ivan and you could comment on that as well.
Yeah, so I think, so the way, it will happen is you will get a lot of those referrals as an outpatient, from outpatient cardiologists, and they will come to the lab, and, we'll see them originally in the recovery area. We'll consent them, we'll bring them in. We'll already have some, perhaps, echo assessments. Not all of them will have, maybe studies or, ischemic function studies. But, if we find, if in the cath lab you find something that is straightforward, let's say, 80% mid RCA and 70% mid LAD, I think, a lot of people would just go ahead and fix this. Or some of them, would say, okay, we found this disease, we'll send you back to the referring cardiologist. We send you back to the referring cardiologist and have a discussion with your cardiologist about what you want us to do, and they can refer them back if they wanted to do PCI, or they can refer them to a surgeon per se. So not always a heart failure, like a heart team per se, discussion would happen. It would be more, the discussion of what interventionalists would think at that time.
Yeah, if I may provide a comment, Yemi, I think just quickly, I think when I look at the survival curve for over the first few years of the trial, like, it doesn't even diverge at all. So I'm not even sure if longer term follow-up is going to show any benefit. But I think my comment I wanted to provide was from the electrophysiology side. Looking at 24 months, ICD therapies in the PCI group was about 6% and was 14% in the medical therapy group. The hazard ratio was 0.42. So they didn't, the 95% interval didn't still cut off one, but of course, this is not power to that endpoint. So there might be some benefits from that regard. And then I also wonder if they underused ICD in this population. I think a third of the population had an ICD. But if you look at the trial, EF at baseline was 27%, and at 12 months, the mean EF was still less than 35%. So you would expect at least 50% of this population getting an ICD, and they had a third of the population. So again, I don't know if that was explored further in the supplementary analysis.
Yes, thank you for that. I didn't talk about, the EP part of this per se in detail, but you're totally correct. They say that 250 patients had an ICD implanted before or within 90 days of randomization. So that would be, 250 out of 700, about a third of the population. And the incidence of ATP was one of their secondary outcomes in this study, and there was more ATP in the optimal medical therapy arm compared to the PCI arm. At the end of the study, it was around 14% versus 6%. So I agree, it was, they didn't talk about this more in detail in their supplementary material from what I looked, but I agree that, if those patients didn't have improvement in their EF, you would expect a larger subset of patients to have ICDs implanted, which was not the case. Perhaps maybe because a lot of them passed away. I'm not sure, but they didn't really explore on that further or discuss that along. This was just, one paragraph in the secondary outcome results.
Okay, any other questions? It's 8:31. Okay, again, Dr. Ismail, thank you so much for your excellent review and great presentation. And
thank you for having me.
Again, welcome to St. John. I hope you will have a very productive month here. Thank you, everyone.
Thank you.
And have a good day. Bye.
Thank you.